Hi, my name is Nate Miller. I'm a student physical therapist at Campbell University, and today we're going to be talking about anterior and posterior glides at the acromioclavicular joint. So to start off, explaining what joint mobilizations are is it's basically a skilled passive physiological movement that a therapist does to a joint of a patient, and the purpose of joint mobilizations are to restore optimal motion, restore function, and or reduce the pain in a joint. Today we're going to be focusing on grades 1 of mobilizations, and that's when pain is the main restriction. So it's a small amplitude rhythmic oscillatory movement. Um, and whenever you're applying joint mobilizations to a patient, make sure that you start with the lower grades before you move on to the higher grades. So talking about the acromioclavicular joint, I have a model here to demonstrate where we're going to be treating today. So the acromioclavicular joint is right here. It's a synovial plane joint. It's made up of the clavicle, the distal end of the clavicle, and then the acromion. So for the stabilizing hand during this movement, this mobilization, the stabilizing hand, the fingers come up to the front, the anterior side of the acromion, and then the thumb goes along the spine of the scapula. And that's where you're going to be stabilizing. The treatment hand, if you're treating in an anterior direction, so an AP mobilization, the thumb is going to come to the back of the clavicle, the posterior edge, and you're going to be pushing anteriorly. The opposite direction, PA mob, or an AP mob, the fingers coming up front are going to just pull on the clavicle and move it posteriorly away from the acromion. So I have a patient here, Richie, and Richie's main restriction is pain. So we're going to be doing a grade 1 mobilization on Richie. So I'm just going to explain to Richie. Richie, I've noticed some restrictions in your acromioclavicular joint, which is right here. It's made up of your clavicle and your acromion. So we're going to be doing some light oscillatory movements at the joint, and that's just going to help decrease your pain and hopefully restore some function. Is that okay?
Sure.
So this shouldn't be painful, so if you do have a lot of pain, just let me know and we'll stop. Okay. So the patient's just sitting relaxed. The therapist comes to the side of the patient, and the stabilizing hand palpates for the acromion and the spine of the scapula. The anterior part of the fingers come to the anterior acromion and stabilize there. The thumb, once you find the spine of the scapula, goes along there. And then your treatment hand palpates the clavicle, follows it distally into the attachment of the AC joint, and grabs it. So we're going to start with the posterior mobilization. And so I'm just going to oscillate that posteriorly as I stabilize. Any pain with that, Richie?
No, feels good.
Good. So if we were to mobilize in an anterior direction, then the thumb is coming behind the clavicle, again palpating the clavicle to its distal insertion into the AC joint, and then the thumb is going to push anteriorly. Any pain with that, Richie?
No.
Good. And so we're making sure our oscillations just go to the restriction of pain. We don't want to push too hard into the tissue resistance. Okay. So articles have stated that the main limitations at the AC joint occur with internal rotation and horizontal abduction. So to treat for those biases, first starting with an internal rotation bias, we're going to take the patient's arm and place it in maximal internal rotation at the shoulder, so we can place it behind the patient's back, and you're just going to rest it there. And then once we have the patient's arm in that position, then we can go on and treat just like we did before for the anterior and the posterior mobs. And that'll help restore some of that internal rotation. The second one, for a horizontal abduction bias, we want to take, could you face this table please? And go ahead and place this arm, face your body in that direction. Good, so his arm is now horizontally abducted. I'm going to raise the table a little bit just so we get in between 60 and 90 degrees. Again, the hand is going to palpate for the acromion, stabilize the acromion and along the spine of the scapula. The treatment hand is going to find the clavicle, the distal end, and then we're just going to do our modes like we talked about before again to treat for horizontal abduction restriction.